Thank you. Being in the need to implant Toric IOL in the presence of posterior capsule rupture can always be challenging, not only in terms of a decision you have to take, but also from surgical point of view. So this is a lady, 47 years old lady, who came for cataract surgery, and that was some 8 years ago. And she wanted to be spectacle independent afterwards. We proposed her phaco emulsification and restored Toric IOL because she had an astigmatism, and the right eye was an uneventful surgery, but the second eye, the left one, had posterior capsule rupture with limited vitreous loss. And this is the video. We perform a PCR enlargement. It has an oval shape, but the aim is to perform a continuous break in the posterior capsule, so there is no danger for it to be enlarged when you implant the IOL in the bag, and this is what we did. We implanted the restored Toric IOL in the bag, and we were able to put it on the axis which was necessary to be implanted, and everything was fine till the end. This lady, after 7 years after the surgery, she sees 20/20 because we followed up, and she's doing quite well. We have to rotate, so we implanted a vertical axis, but it was more than 15 degrees in comparison with the axis needed, and we had to rotate very carefully until we reached the final axis. So this is the object refraction post-operatively. Uncorrected distance near intermediate visual acuity was 20/20 plano. Again, 1FC in our language means 20/20 plano. And the axis, as you see, the refraction, post-op refraction here is 0, so it's quite very well. So very good results despite the posterior capsule rupture. This is, I would say, more unhappy case. It was done by our youngest colleague, who recently came in our clinic, a brave surgeon, young surgeon, and he had this complication during the surgery, which made him not sleeping for 2 weeks maybe. A 72-year-old male patient came for cataract surgery presenting with +3 cataract associated with astigmatism, and during the phaco, while there was still some epinucleus and cortex inside, he broke the capsule. I took the case, I continue, I managed to perform a local vitrectomy via the paracentesis, and as you will see on the pictures following, I consider that I have enough posterior capsule lateral here and here. And fortunately, the axis to be implanted was here. You can see the blue spots here. So I implanted through the main incision, and very carefully with a lot of OVD, you need to rotate it. You don't want to enlarge the posterior capsule break. You don't want to mess too much with the vitreous, which you considered you clean it quite nicely. And this is a very unguided, correct position of the Toric IOL in the bag. The first day post-op and 1 week post-op, the PCOIO was well centered. The visual acuity was 0.7. We were quite happy. This is the break in the anterior capsular axis, which was the cause of the run out and posterior capsular axis, posterior rupture. And these are the spots on the IOL. It is an Clarion IOL, a Toric, and it is put on the axis, on the desired axis. At 1 month post-op, PC IOL is well centered on the axis that we want it to be, normal IOP. The patient had a few days of high IOP, but everything went away. Uncorrected visual acuity 20/20 with plano, but he was very happy, no complaints, but he developed an inferior retinal detachment that we noticed only when we dilated the pupil. Meanwhile, we operated. I operated this case, and the retina is attached, and the visual acuity is 20/20 again. He still had a bit of air bubble up in the vitreous cavity, but he was happy. The discussion which needs to be done is, should you put the Toric IOL in presence of the posterior capsule rupture? Yes, when the PCR is controllable and it can be converted into posterior continuous capsulotomy, as you saw in my first case, no matter round or oval, but continuous, multifocal IOL and Toric IOLs can be implanted safely in the bag. Even with a non-continuous posterior capsule break, a Toric IOL can be still implanted depending on the PCR size and on the axis to be implanted. Like in the last case of Ahmed, last cases, I don't know if he could have implanted, he couldn't put safely an IOL on the axis. If the axis needed, was it on the rupture placement. But there are some conditions. You need to fill the bag with OVD before implantation. Hydroimplantation, which I do in 99 of the cases, 99%, is avoided in these cases. And complete washing out of the OVD at the end and leaving the eye a bit hypertonic are in the favor of a good IOL stability. Future complications are possible, unrelated to the type of IOL, but related to the type of complication, posterior capsule rupture. Thank you.